Yeah, sorry, I'm not even this, but so thank you, Jay and AIUS, for giving me this opportunity to present this recent case I saw. To be or not to be, with apologies to Shakespeare. This case was a 56-year-old man with no reported systemic disease or any prolonged drug intake. He had undergone a cataract surgery with intraocular lens implantation in the right eye 2 months ago and had an immature cataract in the left eye. But the surgery apparently did not improve his vision, which remained 6 by 36 part in both the eyes. His intraocular pressures were normal. There was no family history of any visual impairment. He had two sons. Unfortunately, one is no more. And the other, who is alive, he's absolutely reluctant to come here for examination. So I just have the patient for you. This is the fundus picture of the patient, 56-year-old. Again, I must remind you, 56-year-old man. So looks like a serious detachment to me, with some deposits below and multiple PD kind of lesions. And in the right eye, there is a central scar. Left eye has a hazy view because of cataract. The first thing I wanted to do was a fluorescein, autofluorescence imaging. So I have to say that we have a flash-based imaging and not an SLO-based. So it did show the central hypersignals, halos, you can say, along the central ring of detachment. And there was some hyperreflectivity, which was plus minus in the peripheral lesions as well. So I could not decide whether we are dealing with an autosomal recessive BEST or chronic CSCR, but it looked more like chronic CSCR at this stage. If you look at the OCT, you have all features of CSCR, like you have a pigment epithelial detachment. Now, when you see a PED, you of course think of a CSCR. It had PEDs at two places, one just temporal to the macula, and one above the macula in the papillomacular bundle. So these are the two PEDs in the right eye. And there was a similar appearance of the serous detachment in both the eyes, with subretinal fibrin or photoreceptor debris kind of picture. There was a definite pachychoroid, and it was not just a pachy vessels. There was actually an increased thickness of choroid, especially in view of the age of the patient. The central choroid was 434 in the right eye and 387 in the left eye. Now the question arises, are we looking at SRF or something else? So first thing to see is, when you do a vertical scan, in the lower part, you see this hyperreflective deposits actually. And if you look at more carefully at the image, even though it's a regular spectral domain OCT, you can see that what we are looking at the deposits within the retina, not just only under the retina. So because the layer that you are seeing is not the undersurface of the retina, it is actually the external limiting membrane, if you note the continuity here. Just for comparison, I just have put another case with CSCR, and this is how subretinal fibrin looks like. And you can see the external limiting membrane very clearly intact all through. When I did a fluorescein angiography with this patient, again, I could confirm the PEDs. So there are two PEDs in the right eye, and there's a set of PEDs in the left eye also. So again, it made me think of CSCR. Now, mind you that there's only PEDs, but they're not leaking. Not only there is no active leak, there is not even an ooze, as first described by Dr. Yanuzzi and their group. The central scar showed that it was just a area of atrophy and not an area of scarring. Now, if you note that the fluid in the this so-called SRF was not uniformly homogeneous reflectivity. It was a flocculated kind of appearance of fluid actually. So it was not looking like fluid. And you can see this black hyposignals at the bottom on the fluorescein angiography, which is corresponding with the hyperautofluorescence in the previous image. So if you look at the differential diagnosis of the vitelliform lesions, it is pretty large. But what we are primarily probably looking at is CSC or Best disease. There could be AMD, large drusen, cuticular drusen, or drusenoid PEDs. There could be pseudoxanthoma elasticum, epiretinal membrane, vitreomacular traction, MACTEL2, or as been discussed previously in a different manner, paraneoplastic syndromes, in which the eye generally gets involved only later when the patient already has a systemic malignancy. One disease which mimics to this condition to some extent is AEPVM, and this has been recently diagnosed by Yanuzzi's group. But they have extensive multiple serous detachment, which primarily develop acutely, as the name itself suggests, and they resolve spontaneously. And vitelliform lesions are not necessarily at the serous detachment stage, like in our patient. So the points in favor of chronic CSC is OCT shows PED. There is a pachychoroid, not just pachy vessels, but actual thickened choroid for a 56-year-old. Autofluorescence shows multifoci of diffuse RP decompensation, but I'm not sure whether those there is any hyper signals in the extrafoveal sites, because it is not an SLO-based autofluorescence imaging. The features in favor of BEST is it is clinical classic vitelliform appearance with bilateral symmetry, which is important. OCT shows not just subretinal, but also deep retinal lipofuscin or whatever debris you call it. And PEDs as well as pachychoroid have both been described in BEST disease. Autofluorescence shows hypersignals encircling, which is very classic of BEST. Of course, we don't have an EOG, we don't have genetic testing, and we don't have the son's eye examination, which is really lacking. A follow-up could settle the issue because choroid thins with age in chronic CSC, but it thickens to some extent in BEST disease. So this is one dilemma, the diagnosis. The other dilemma is whether to treat or not to treat, because angiography does not show any active leaks or even oozes, only PEDs. ICG was not done, and anyway, we don't have an SLO-based ICG. OCT shows submacular material, which is unlike the SRF and CSC, and it is unlikely to get absorbed. It is most likely intraretinal also. Finally, PED dye is not available in the country. The laser, including micropulse, in spite of my colleague's presentation, is a weak alternative as shown by PLACE trial, and Eplerenone is still weaker trial as been shown recently. Thank you very much.